Chapter 13, Peripheral Nerve Disorders and Management. So because our nerves stem from the trunk and they run the length of our extremities, they can be subject to stress and strain with different musculoskeletal injuries, overuse injuries, those types of things. And so we can see peripheral nerve involvement in our orthopedic conditions as well, and we need to be mindful of the activity limitations that those can pose. So let's do a quick review of the types of neurons that we have in our peripheral nervous system. And this is on page 399, box 13.1 talks about each of these, but I made my own little table here. So our alpha motor neurons, they're going to be located in our anterior column in the anterior horn, and they serve to innervate from the central nervous system to our skeletal muscles. Our gamma motor neurons are located in the lateral columns in the lateral horn, and they serve to innervate the muscle spindles to help contribute to proprioception. Our sensory neurons are located in the dorsal root ganglia, and they are our sensory receptors to the central nervous system. And our sympathetic nervous system, or sympathetic neurons, are located in the sympathetic ganglia, and they provide innervation to our viscera, like our organs, our glands, and our vessels. Nerves are designed to conduct impulses and send signals and receive signals, but they also have to have enough mobility to move with the body, right? They start from the trunk, they get pulled when we move our extremities the same way that our muscles get pulled, right? They have to have the mobility to stretch a certain amount of space. They have to be able to floss and glide through different spaces as we move in order to decrease the potential risk for injury. And so we have to see those mobility characteristics of the nervous system, and that's something that we shoot to restore as part of therapy. We can have injury to the peripheral nervous system at different sites. We can see it at the nerve root level, and so that's going to associate with our dermatomes and myotomes, and they'll present consistent with the nerve root level that is affected. We can have plexus injuries. So for the upper extremity, we'll look at brachial plexus injuries. The brachial plexus is going to be made from spinal nerve roots C5 to T1. We can have upper plexus injuries that will involve C5 and C6, and this is going to be our most common type of brachial plexus injury. We'll call it Erb's palsy, and it creates a waiter's tip, and I have a picture of that coming up here. But the waiter's tip presentation is a loss of shoulder abduction, a loss of shoulder external rotation, and a loss of elbow flexion. Middle plexus injuries are rare. They're caused by an anteroposterior trauma, and they only affect C7. And so they can happen, but they are just rare, and so we don't talk much about them. Lower plexus injuries are going to be injuries to C8 and T1 nerve roots, and that's going to be our Klumpke's palsy, and that's going to present with hand weakness, and these are often birth-related. So there's injury to the brachial plexus as the baby is descending the birth canal that stretches the brachial plexus, causing a lower plexus injury and resulting in a Klumpke's palsy. We can have complete or total injuries of the brachial plexus. And another injury type that usually has short-term symptoms would be a stinger injury, and that's when we see the upper extremity pulled in one direction as the head and neck flex the opposite direction laterally, causing tension through that brachial plexus and potential injury. So this is that waiter's tip position that I talked about, where we have the loss of shoulder abduction and external rotation and weakness of the elbow flexors. In supinators, we see the arm is internally rotated there, tucked close to the body, and the elbow is extended with the hand just kind of hanging down. And it's named after a posture for a waiter sticking their hand behind them to receive a tip before walking away from somebody. And so I don't know if that helps you with remembering it, but that is where it gets its name from. We look at the nerves that branch off of the brachial plexus, and that's going to include our axillary nerve, musculocutaneous nerve, median nerve, ulnar nerve, and radial nerve for our primary nerves of the upper extremity. We do have other nerves like our long thoracic that branches off from our brachial plexus. Damage to our long thoracic nerve can cause scapular winging because that's our innervation to serratus anterior. But our primary nerves to the upper extremity that we really want to focus on here are going to be these five. So our axillary nerve comes from nerve roots C5 and C6. Musculocutaneous comes from nerve roots C5 and C6 as well. The median nerve is innervated from C6 to C8. Our ulnar nerve is C8 and T1. And then our radial nerve is C6, C7, C8, and T1. Be able to determine the likely nerve that is affected by the cervical level based on which ones they come from or originate from. You guys do not have this slide, but I worked long and hard on creating some mnemonics to help you understand what the peripheral nerves go to. And so our axillary nerve coming from C5 and C6, like we just talked about, affects lateral rotation or external rotation and abduction. So if you think A for axillary and A for abduction, that's what we're going to see loss of function in if the axillary nerve is affected. Our musculocutaneous nerve is C5 and C6, and it affects elbow flexion. And you can see my little muscle man here that I drew. When I draw a stick figure and you think of adding muscles to a stick figure, you think of giving them biceps, and our biceps flex our elbow. And that's also what is innervated by our musculocutaneous nerve. And so our muscles go with the musculocutaneous nerve, and we would lose elbow flexion if the musculocutaneous nerve was affected. The median nerve, C6 to C8, affects wrist and finger flexion. So think of carpal tunnel syndrome. The median nerve runs through the carpal tunnel with the long finger flexors. And so if we can think of finger flexion and the wrist flexion that accompanies that, we can couple median nerve with wrist and finger flexion loss. Our ulnar nerve, C8 to T1, affects the intrinsic hand muscles. So if you see the picture of my hand there, your hand can't make a U for ulnar nerve if you have an affected ulnar nerve. And then radial nerve, C6 to C8, T1 affects our extensors. We've talked a lot about how the radial nerve runs in the posterior arm and affects our extensors. And so I don't have a specific one for that, but I did tie it to the overall mnemonic. So a muscled man understands revving, because muscled for musculocutaneous helps keep that in check. And then revving, if you think about revving a motorcycle, you are extending your wrist, and so that's to help cue you towards radial for extensors. The lumbosacral plexus is going to be our primary innervation for our lower extremity, and we've got three main nerves that branch off of our lumbosacral plexus. Our femoral nerve and our obturator nerve are going to come from the lumbar plexus, and the sciatic nerve is going to come from the sacral plexus. And then our sciatic nerve descends our posterior lower extremity and branches into the tibial posterior tibial nerve and the common fibular nerve. The femoral nerve comes from L2 to L4. The obturator nerve comes from L2 to L4. The sciatic nerve comes from L4, L5, S1, S3. Tibial posterior nerve comes from tibial posterior tibial nerve comes from L4, L5, S1, S3. That's the same as the sciatic nerve, remembering that branches off of it. The common fibular nerve originates from L4, L5, S1, S2, almost the same as the sciatic nerve, just missing S3 there. Again, remember to know your nerve root levels. Femoral and obturator come from the lumbar plexus, so they're going to originate a little bit higher. That's where we have L2, L3, and L4. My fun-filled mnemonics for the lumbosacral plexus, I've got free obituaries sold to commoners, which I know makes really no sense at all, but it's random enough that it just might stick. This one doesn't exactly tie to the function the same way that the other ones did for the upper extremity and the brachial plexus, but hopefully you enjoy what I've got here for. Femoral nerve, L2 to L4, affects our hip flexors and knee extensors. So think of F for front of femur, which is where our quads are located, and our quads contribute to hip flexion and knee extension. Our obturator nerve, it's L2 to L4, and that affects our adductors. So you think like, oh no, you will not get between my legs. You're adducting your legs because your obturator nerve innervates your adductors. Sciatic nerve, L4, L5, S1 to S3. Affects hip extensors and knee flexors. And so my little stick figure here, I'm going to see if I can draw over it to show you. So this is somebody with their hip extended and their knee flexed. And if you look, you can see the S for sciatic nerve. Your tibial / posterior tibial nerve, L4, L5, S1 to S3, affects your plantar flexors, so posterior tibial nerve for your plantar flexors and your toe flexors. And then your common fibular nerve affects flexion, so affects dorsiflexion is what that's supposed to say, but apparently I only wanted to type half the word. So it affects dorsiflexion, so you want to think the fibula flexes the foot forward. Remember, we talked about how nerve injuries can happen at the nerve root, and so this is an important time to review your dermatomes and myotomes. I've got your myotomes listed out here as a reminder, so thinking C4 for scapular elevation, C5 shoulder abduction, C6 wrist extension, C7 elbow extension, C8 finger flexion, T1 finger abduction. And then for the lower extremities, L2 hip flexion, L3 knee extension, L4 dorsiflexion, L5 great toe extension, S1 plantar flexion, and S2 knee flexion. Don't forget to do your dance. We know where nerves can get damaged, and we know what type of loss the patient would experience if the nerve was damaged at a specific place. But how do those nerves get damaged? So nerves can get damaged through compression, where the nerve is pinched, squeezed, compressed in an area. Laceration, typically due to an injury, like a cutting, so a stab wound would be a great example of a laceration, potential risk to nerve injury. Stretch, so a traction force has been applied to the nerve, and so it has a stretch injury. Patients receiving radiation can experience peripheral nerve injuries. Electric shock, so somebody getting electrocuted, or lightning strikes, those types of things. And injection, we can see peripheral nerve injury through IV injections. Somebody's trying to hit the vein, doesn't hit the right place, and causes a peripheral nerve injury. Injuries will present in a variety of sensory and motor involvement for patients depending on where the injury has occurred and the extent of damage that the nerve has experienced. The most serious injury to a peripheral nerve is marked by muscle flaccidity and numbness to the area. After injury, we expect to see recovery, and our hallmark symptoms of nerve reinnervation include hypersensitivity and volitional muscle contraction, so meaning muscle contraction that somebody is in control of. That hypersensitivity can be a big issue for patients, and one of the things that we treat in therapy with our desensitization techniques. Recovery is dependent on several factors, first being the nature and the level of the injury, so where the injury occurred and how severe the injury was. More proximal injuries typically take longer to recover, not only because of the proximal placement, meaning they have a longer distance to fully regenerate if they have to fully regenerate the length of the limb, but also because of the involvement. When we affect a nerve more proximally, it has increased mixture of sensory and motor, and so we have more involvement overall with proximal injuries. Nerve tissues regenerate at the rate of 1 millimeter per day, so again, another reason why proximal injuries can take longer to recover. That it's not exactly the fastest rate. Timing and technique of repair, so if we have to have surgical repair to the nerve, the surgeon's skill, how they apply that skill, what technique they take, and how quickly they are able to intervene on the nerve damage can all affect the amount of recovery that we expect. And the age and the motivation of the patient. Patients that are younger typically have a higher recovery potential. Patients with higher motivation have a higher recovery potential. Outcomes of nerve regeneration, we can see it present in several different ways. We've got 5 listed in your textbook. So we can have an exact innervation of the native target organ with return function, so everything goes back to normal. We can have the reinnervation going to the native target organ, but there's no return of function due to degeneration of the end organ. So if the muscle is the end organ and it has degenerated, or the neuromuscular junction has degenerated that it can no longer receive the neural impulse, then we would see continued flaccidity within that muscle. The wrong receptor can be reinnervated, and so we've got nerves firing, causing wonky signals and outcomes that we're not looking for. We can have receptor reinnervation in the wrong territory, causing false localization of input, or we can have no connection to an end organ. We have specific guidelines that we'll talk about for managing nerve injuries based on specific diagnoses, but some general things that we're going to talk about are the phases of nerve injury and how we would handle those. So during the acute phase of nerve injury, we really want to protect things, right? So we're going to control pain and edema with elevation and compression as appropriate. We can provide compression distally to prevent swelling distal in the extremity, but we don't want to provide compression over top of the injured nerve. We're going to give patient education over pain management and that compression advice. We want to protect the affected areas, especially if there's loss of sensation distally. So if the hands or feet are affected, we're going to educate them to wear gloves or shoes, depending on which one is involved. We want to decrease weight bearing on affected areas as possible, especially, again, if there's a loss of sensation. We don't want to have somebody standing for prolonged periods or leaning on that hand for prolonged periods and having any risk or further risk of injury. And we want to ensure that the protection that we do educate them to wear is never too tight. So we don't want snug fitting gloves on. We don't want tight fitting shoes. We want them to have space to breathe, but protection to keep them safe from external harm. And we'll use modalities as needed as part of our pain management. We might also help patients understand the appropriate use of orthotics to immobilize them so that way the nerve doesn't have further tensioning that can cause damage and limits the position of compression depending on what the original source of that injury was. Recovery means reinnervation. Okay, I definitely didn't really mean to sing that originally, but I didn't notice the typo until I started to go ahead and record here. But during the recovery phase, we're seeing signs of reinnervation, and so I hope that that is a memorable way for you to know that the recovery phase is for seeing signs of reinnervation, and that's when we're going to get return of that volitional muscle contraction and hypersensitivity. Remember, those are our hallmark signs of reinnervation. We're going to utilize nerve gliding and flossing in order to remain healthy. A nerve must have the freedom to move and glide as the body changes positions. So we will go over nerve gliding and flossing techniques in class as part of the lab activity, but that is going to be an important part of our recovery phase so that we can train the nerve and the tissues around it to give it the freedom to move as the body moves. We're going to implement motor retraining techniques, so we'll use place and hold to whatever muscle has been affected. We'll put it in a shortened position passively for the patient, and then we'll have the patient isometrically try to hold it in that position. So the only thing they're trying to maintain against is potentially the force of gravity if they're prepared for it. If not, we'll try a gravity eliminated position and still do the place and hold. We want to minimize stresses on the nerve tissue while trying to reinnervate the musculature that has lost innervation. We can use things like neuromuscular electrical stimulation, which you guys will cover more in physical agents. And we will use gravity-eliminated range of motion techniques, trying not to make them move against gravity, potentially hold against gravity, but not move against gravity until we have greater innervation and stability around the joints. Desensitization techniques are going to be a big component to what we do with these patients because hypersensitivity is one of the hallmark signs of returning innervation, right? And so somebody who is hypersensitive has a hard time participating in normal function because everything hurts or everything's extra cold or it's abnormal perception of pain that we have to retrain for this patient. Desensitization is going to be about exposure to different types of textures, right? So we have cotton balls and pasta and rice and Velcro and all different types of textures that people normally can have adverse responses to, but we have to make sure that we try to recondition the patient to their prior level of function and their ability to tolerate these textures. And so we will slowly expose them to the textures and then have them run their hands through those textures, have them perform exercises within those textures so that way they are fully being exposed to them. And so desensitization is a really big part of our recovery phase of nerve injuries. Box 13.5 talks about some desensitization techniques that we are going to go over in class. Box 13.5 also talks about discriminative sensory reeducation, and that's on page 412 in case you don't know where to look for that. But discriminative sensory reeducation is basically teaching somebody how to understand what it is they are feeling by slowly introducing it to them with other visual or other sensory input, such as visual input, and then progressively taking that away so that they can learn to identify things by touch. And this is a part of restoring their sterognosis. A patient has reached the chronic phase of nerve recovery when they have significant residual effects from the nerve injury and the lack of regeneration, and they have to learn how to compensate for function. So for these patients, we're going to focus on compensatory function. We're not going to do that during the recovery phase. We want to try to maximize function as much as we can and limit compensations. But if we've deemed that the patient has moved to the chronic phase where we're not going to regain what has been lost, we have to restore function as best we can and teach them the ways to compensate safely. And we're also going to teach them preventative care. Again, especially if there's sensory loss, we need to do protective things like not walking around barefoot, especially on outdoor environments, but even indoor surfaces can be dangerous to walk around barefoot because if a patient can't perceive that there's damage to the bottom of their foot, then they're never going to know to check it. We also need to teach them on skin checks and being sure to inspect areas that they are desensitized in so that they don't risk injury that they are unaware of. Neurodynamic disorders are a group of neural presentations that exist where basically the peripheral structure isn't able to move through the body the way it needs to, and so it has increased tension developing on it because it's not gliding and sliding through the spaces that it needs to glide and slide through. We can determine if somebody is experiencing a neurodynamic disorder with a patient history and if their pain is provoked through specific through specific positions, but we can also use tests of provocation, and those are going to be our neural tension tests that we're going to go over in class during the lab activity. Causes, again, are going to be that the nerve is stuck somewhere and it's not able to move the way it needs to when the body moves. And that can be adhesions, that can be scar tissue, that can be muscle tightness. There's a lot of causes for it being stuck, and we have to address that on a patient-by-patient basis. But something is stuck. Principles of management are going to include neural sliding and flossing techniques so that we can get it to glide and slide in the spaces that it needs to glide and slide. And we're going to go over those in class and practice in lab as well. Before doing neural tension testing or treatment, we want to make sure that we think about the impact that the position and the movement is going to have on other tissues, and then we limit the risk of injury in potentially damaged tissues. Remember that a lot of nerve injuries can be a result of orthopedic or overuse injuries, and so we might have multiple injured structures. We want to recognize the irritability of those involved structures and how much the activity is going to increase pain. Recognize the rate of symptom progression. So if it does increase pain, how quickly does that pain progress, and do we need to back off immediately, or is it staying pretty stable and we can push a little bit? But paying attention to those things is important. We want to use care with active pathologies or diseases, so if we know they have something else going on, we want to take special consideration and watch for signs of vascular compromise, and that's going to be things like temperature changes distal to the area of movement, loss of pulses distal to the area of movement, color changes in the skin, paying attention to those kind of vascular compromise indications. Contraindications are reasons to say, nope, definitely not doing that. This is not the patient I'm going to do this on, and those are going to include patients with acute or unstable neurological signs. So if they are newly onsetting or they have an unstable presentation, then we're not going to do tension testing on these patients. If they have cauda equina symptoms, so that's going to include like numbness in the groin or loss of bowel or bladder control, we don't want to do neural tension testing on these patients, and we're probably going to let the supervising PT know and have them referred back to the doctor. Spinal cord injury or spinal cord injury symptoms, we don't want to pull increased tension, and we are probably not going to get the same reliability of results in this patient population, and so for safety purposes, this is a contraindicated population. Any patient with a neoplasm, so a new growth that we don't know what it is, and we don't want to risk excessive movement to the area, we don't want to do tension tests there. And then patients with infection, we're not going to do tension testing in, or active infection at least. If it's being managed, you may receive orders for tension testing if they're like on antibiotics and it's being controlled and their lab values indicate that it is not an active infection any longer. But anyways, what are tension tests? And so neural testing is going to have a couple of techniques that we'll go over for the upper extremity and a couple of techniques that we'll go over for the lower extremity. We're going to practice these in class, we're going to demonstrate them in class, and there's also a couple of videos embedded through this lecture that you can watch independently to understand what's going on for the positions and give yourself kind of a good frame of reference before walking into lab. So for the upper extremity, upper limb, I think it's neurodynamic testing. When I learned it, it was ULTT for upper limb tension testing. And so I'll have to double check on what that abbreviation is, but I'm pretty sure it's upper limb neurodynamic test 1 is going to be figure 1313 on page 415 in your textbook, and that's going to help to tension the median nerve and test for median nerve involvement. This is a good test to perform in patients with carpal tunnel syndrome to really help determine the location of the nerve compression. Carpal tunnel syndrome can present, and we assume that the compression is at the carpal tunnel, but we might experience nerve compression somewhere else, and that's one of those things that we call as a double crush injury, where everybody has the God-given right to have multiple things wrong with them, and every nerve has the God-given right to have injury within two places in itself. Upper limb neurodynamic test 2 is figure 1314. I believe it's on the same page, 415. And that's going to stress the radial nerve and provide the most tension to the radial nerve to bias that for testing. And this would be appropriate for patients with tennis elbow and de-Quervain syndrome. And the upper limb neurodynamic test 3 is going to stress our ulnar nerve. That's figure 1315 on page 416. And this is good for patients with medial epicondylitis, again, to see how much the nerve is involved in the orthopedic condition. We will practice these in class, but take a look at them in your textbook and watch the video here. I'm not going to play the videos in the lecture in this video, typically because it just doesn't work, and so I don't want to assume that that's going to happen. I do want you to use your PowerPoint version on Canvas to watch these videos. They are embedded in there so that if you download the PowerPoint, you can watch them through there. For this video specifically, I want you to note that they are labeled differently than your textbook, and so in order to limit confusion, you're looking at upper limb tension test A, C, and D in this video, and that's going to equate like I have written there on the side. Taking a look at the lower extremity, we've got 2 tests for our sciatic nerve and 1 test for our femoral nerve. So our straight leg raise on figure 1316 on page 416 is going to show us a neural tension technique for our sciatic nerve, and it can help us to identify whether sciatic nerve impingement is coming from the lumbar spine, or another common place of impingement for the sciatic nerve is between the heads of the piriformis. As it passes through there and the piriformis is tight, it can compress the sciatic nerve, and so use of these tension tests can help us to determine where that compression is occurring. The straight leg raise can also be used as a good neural slide flossing technique, and again, we'll go over these in class so you'll understand what we're looking at here, and there are the videos embedded in the lecture. And then the slump sitting maneuver, also for the sciatic nerve, is going to be figure 1317 on page 417, and it's essentially a seated straight leg raise, but where you can add in more lumbar flexion, so you can really, again, help determine the source of compression, whether it's at that lumbar spine or the piriformis. The femoral nerve can be tested with the prone knee bend, figure 1318 on page 417, and that test is performed just how it is named. The patient is in prone, and the knee bends so that their hip maintains in at least a neutral or slightly extended position, and you tension the femoral nerve by bending the knee. Same thing for the last video. Go ahead and watch it embedded in your lecture, but I'm not going to try to play it through here. Same thing. Same thing. This video covers neural flossing, which again we'll go over in lab, but if you'd like to check it out before class to give yourself good footing, that might be a good idea. And this is also on nerve gliding and sliding exercises. Again, we're going to go over these in class, but it is helpful and it's a good reference for you to have during our lab time. Let's talk about a couple specific peripheral nerve injuries that we might see in therapy and how we'll treat them. So thoracic outlet syndrome is our first one we'll talk about here, and that can be presented as vascular thoracic outlet syndrome or neurogenic thoracic outlet syndrome, and that's where we can see either more compression of the vascular structures or more compression of the nerve structures. This can be caused by a compressive neuropathy, a patient with a faulty posture, or entrapment of neural tissue from scar tissue or pressure. Sites of compression for thoracic outlet syndrome can be in one of these 3 areas. And so to talk about these 3 areas, the first thing I want you to do is take your left hand and put it on the superior aspect of your right clavicle. And then you're going to take your right hand and put it just above your right ear. And I want you to resist right lateral flexion of your head at your cervical spine and feel the muscles pop up underneath your fingers on your clavicle. And you can feel the gap between your anterior scalene and your middle and posterior scalenes. That is your interscalene triangle. So that's the first area that we can experience thoracic outlet syndrome, the first site of compression. Next is going to be your costoclavicular space, so that's going to be the space between your clavicle and your first rib. And then we have our retropectoralis minor space, and that's going to be where those structures run behind pec minor. And if we have tightness in pec minor, we can have compression of those structures. Common impairments in this patient population are going to include neurovascular symptoms such as pain, paresthesias, numbness, weakness, discoloration or in the distal extremity, and we can experience decreased pulse in the distal extremity. Muscle length strength imbalances. So in thoracic outlet syndrome, we're more commonly going to see anterior tightness with posterior weakness. Remember, a tight muscle doesn't have to be a strong muscle, and so just because it's tight doesn't mean it's strong. Once we stretch it, we need to strengthen it. So we're going to experience weakness on both sides, but we can think of it as tightness on one side, stretch weakness on the opposite side. These patients will also demonstrate a faulty posture, poor postural endurance in the postural muscles, and altered respiration can occur as a result of different muscle activation on the thoracic spine and rib cage as a result of postural abnormalities, muscle alignment, all of those things. These patients will experience difficulty with sleeping, difficulty carrying things with shoulder straps like backpacks, purses, difficulty maintaining prolonged overhead reach, and difficulty with prolonged sitting, especially if they have a more kyphotic posture. Non-operative management, you can check out box 13.8 in your textbook on page 420, but we're going to look to educate these patients on things like posture correction, modifying the things that bother them, those activities and provocative stresses, and teaching them a safe home exercise program, primarily to increase the space wherever they're having compression and ensure appropriate neural gliding. We're going to correct the impaired posture like you talked about with Ms. Scott. We're going to mobilize restricted neurological tissues, so neural flossing gliding techniques. We're going to mobilize the restrictive joints and connective tissues, so we're going to look to things like the neck and shoulder to ensure that there aren't range of motion limitations there because of other soft tissue structures that might be inhibiting the neural movement, and try to alleviate those factors. We'll improve muscle performance, probably focusing on scapular control first, so that way we have proximal stability, but we want to ensure that we have appropriate strength, especially if there's somebody who experiences symptoms with overhead motion. We want to make sure that we have appropriate strength for overhead motion. We want to correct faulty breathing patterns, so if they've had their breathing patterns impaired by the impacts of thoracic outlet syndrome, that we want to teach them how to breathe correctly with the right muscles and limited accessory muscle involvement, and progress functional independence so that the patient can return to their prior level of function. Precautions with this population, we want to watch for worsening symptoms, especially with shoulder girdle exercises, and especially of neurovascular symptoms, because if we have compression of the vascular structures more, especially as we implement scapular movement, then we may see further injury to the patient, and so we want to make sure that we're able to communicate those things appropriately. Moving on to carpal tunnel syndrome. So carpal tunnel syndrome is going to be when we have sensory loss and motor weakness in the hand when the median nerve is compressed within the carpal tunnel. The median nerve can be compressed in several locations, one of that being between pronator teres, but the carpal tunnel is its most common location of compression, and so that's what we typically focus on. It's most commonly an overuse syndrome, but it can be due to systemic factors such as pregnancy. An examination can include special tests like Phelan's, and we can look for double crush injuries. Remember, we talked about where the nerve may be compressed in multiple locations. So just because somebody has compression at the carpal tunnel of the median nerve doesn't mean they don't have compression at pronator teres of the median nerve. Common impairments in this patient population are going to be pain, numbness, and tingling, especially with the provocative movements. Impaired posture, there's strong correlation between cervical involvement in patients with carpal tunnel syndrome. Again, remembering that our median nerve is originally stemming from our brachial plexus, which is coming from our nerve roots C5 to T1, and so our cervical spine involvement can definitely contribute to potential development of carpal tunnel syndrome. So we can see impaired posture in these patients that we want to be able to address to prevent recurrence of symptoms in the future. And we can also see weakness and atrophy of the thenar muscles. Remember, that's the meaty part underneath your thumb, and the first and second lumbricals. Activity limitations and participation restrictions that this patient population may experience are going to include fine motor skills that require opposition, things like buttoning a shirt where they need to bring their thumb to their other fingers because of loss of function in those thenar muscles. Avoidance to touch, especially if they have sensitivity issues or loss of sensation that's resulting in hypersensitivity as the nerve reinnervates. Inability to perform sustained or repetitive provoking motions, often like typing, and difficulty sleeping. Non-operative management, you can take a look at box 13.9 on page 423. So nerve protection, activity modification, patient education, and mobility techniques are going to be our real big focus early on in this patient population. We're going to make sure that we are putting them or teaching them how to wear their orthosis and donning it, especially typically at night in this patient population, to keep the wrist in a neutral position so that we're not adversely tensioning that median nerve when it doesn't need to be provoked. Modifying activities, teaching them proper ergonomics, especially if typing or gripping activities are their provocative activities. We want to teach them how to do those things correctly to limit symptom onset. And mobility techniques, again, going back to our neural gliding and flossing that we'll review in lab, those are going to be important so that the median nerve continues to move as the body needs to move, and then identifying other soft tissue structures around the wrist and or elbow that may be contributing to that improper mobility. And we'll also focus on muscle performance and functional independence as the patient progresses, but those first three are going to be our primary focus in the acute phase. But what if they had surgery? I know, we don't know what to do then. Just kidding. Here's what we do. Maximum protection phase. We're going to do wound management and edema control. Obviously, they have an incision, so we want to make sure we're checking that, making sure there's no signs of infection or wound dehiscence, and that we are helping them manage edema properly by not adversely compressing the nerve as it heals or the incision site, but promoting compression for distal edema control. We want to give them patient education, primarily avoiding wrist flexion and extension, active wrist flexion and extension for the first 2 weeks following surgery. We'll give them active tendon gliding exercises, which you guys went over with the hand, and exercises to related areas. So we want to make sure that we're working the forearm, the elbow, the shoulder, and the neck. Remember that cervical involvement correlation for carpal tunnel syndrome. During the moderate and minimum protection phases, we may have to implement scar tissue mobilization as that incision site heals. We're going to have to ensure that we prevent any adverse healing of that or keloiding of the tissues, and we can break down anything around the incision and teaching the patient how to manage that as well. We'll do progressive neuromobilization, so our neural flossing and gliding techniques, progressively increasing the movement on the median nerve, starting small and then increasing as the patient is able to tolerate. Muscle performance will be a focus as we progress the patient, so our isometrics are going to begin around 4 weeks following surgery, and then we'll do pinch and grip exercises by about 6 weeks. So again, we want to start light and work them into more movement and more force generation that's necessary. Dexterity exercises, again, remember that thenar involvement. We're going to have to help work a lot of opposition exercises, training activities that require opposition, like buttoning shirts, those types of things. Desensitization, exposing them to various textures such as cotton balls, sand, pasta, rice, anything that can have that potential hypersensitivity impact that we can help desensitize them to. And then sensory reeducation, remember, restoring what their body understands of their senses and what information they're taking in by progressively reducing other sensory input. Moving on to ulnar nerve compression in the tunnel of Guyon. It is the second leading cause of ulnar nerve compression behind entrapment at the elbow, and so it is something that we can see in physical therapy. These patients are going to have their entrapment occur as the ulnar nerve travels around between the hamate and the pisiform. So we're looking at the medial aspect of the hand there. There's 3 zones for entrapment of the ulnar nerve in the tunnel of Guyon, and that's going to be zone 1, where we have combined sensory and motor loss. Zone 2 will present with just motor loss, and zone 3 will present with just sensory loss. It is caused by prolonged pressure on the medial hand or leaning on extended wrists, like when you're riding a bike, or repetitive gripping with the 4th and 5th digits. These patients will demonstrate a positive Tinel sign, and they may have a partial claw hand deformity. Other impairments that we can see in this patient population include pain and paresthesias in the ulnar palm and the 4th and 5th digits. They'll have hypothenar atrophy because of the innervation of the hypothenar eminence by the ulnar nerve, and restricted mobility, likely as a result of that atrophy. Common activity limitations and participation restrictions will include a decreased grip strength, the inability to use the fourth and fifth digits, and the decreased ability to perform the originally provocative tasks. Non-operative management follows the carpal tunnel syndrome guidelines that we just talked about, and surgical release and postoperative management follows the carpal tunnel syndrome guidelines that we just talked about. So it's really nice and convenient to you that you don't have to memorize separate guidelines. This is a hand-based ulnar gutter splint, and you can see where it covers the medial aspect of the hand to reduce compression over that tunnel of Guyon. And this is a splint that patients can be prescribed to wear following ulnar compression at the tunnel of Guyon. The last up for this chapter is going to be complex regional pain syndrome, or CRPS. And we have three different types of CRPS. So type 1 develops after a noxious event. So that's going to be when there's a lack of oxygen delivery to the area that causes the nerve damage. Type 2 is going to develop after nerve injury from one of the other causes that we talked about earlier in this chapter. And CRPS NOS has a specific cause that is unknown. So they don't really have the specific origin or determining factor determined. That sounded really redundant, but you understand what I mean. Signs and symptoms of CRPS include disproportionate pain or hypersensitivity, prominent autonomic and inflammatory changes in the region of pain, loss of motor function, and symptoms that are worse distally and spread proximally. The clinical course of CRPS is going to present warm in the acute phase and cold in the chronic phase. And it's important to remember in this patient population, as in with most patient populations, early intervention leads to better outcomes compared with delayed intervention. These are some pictures of patients with CRPS. You can see the unilateral involvement with the more distal portion of the extremity is affected. We've got a lot of the neurovascular changes. We can see those trophic changes to the skin where it becomes taut, glossy. We can have hair loss or hair growth that's different. And their pain level is disproportionate to whatever caused the injury. So they have this extreme level of pain, but it's localized to where they're experiencing the CRPS. Impairments in patients with chronic regional pain syndrome are going to include pain and hyperesthesia, which is just going to be an increased sensitivity to the senses, light touch, hot, cold, pain, all of those things. They'll experience motor dysfunction, edema and sweating changes, and vasomotor and trophic changes, like we talked about the skin changes in the last picture. Common activity limitations and participation restrictions will be related to the painful use of the involved extremity. So if it's a lower extremity that's involved, then it's typically things like ambulating. If it is an upper extremity involved, it would be use of the hand for whatever functional task they needed to complete. There's medical and pharmaceutical management, but for physical therapy management, we're going to focus on box 1311 on page 428 in your textbook. So early on, we're really trying to help them limit the pain that they're experiencing. So we'll do pain management and edema control using modalities, retrograde massage, elevation, compression, ice, all of those things. We'll do things to correct their sensorimotor integration, like mirror therapy. So being able to visualize the extremity or the unaffected extremity moving in a mirror can help them to understand why things aren't supposed to be painful when they move the extremity on the affected side, because the mirrored image looks like the affected side to them, and so it can help with desensitization to movement. We can also want to increase their mobility specific to the involved tissues with gentle active range of motion things and joint mobilizations as appropriate. We'll improve muscle performance with light things, active loading, closed chain, functional activities as needed, and aquatic exercise can be a great remedy for this for this population, because as long as they're able to tolerate the temperature of the water, typically the temperature of the water is relaxing and does not increase their symptoms and can allow for greater amounts of movement. We want to improve total body circulation in this population. Remember, they're experiencing some vascular changes as a result of this, and so we want to promote circulation throughout the whole body. And so aquatic exercise can be another area where this is beneficial for this patient population. And we'll do a lot of desensitization things with this population, starting very light with whatever they can tolerate, building into putting the extremity in the textures and having them move through it so that we can build a tolerance to it. And we're going to educate the patient on when they need to worry and how they need to respond. So if they're um, seeing vasomotor changes and how they need to address that to ensure that there's appropriate circulation, whether it's with, squeezing a ball or performing ankle pumps as appropriate. We want to educate them on protecting areas that have hypersensitivity while also not compensating and affecting other areas where they're causing tissue shortening or muscle atrophy because of a lack of use. And in the chronic stage with CRPS, we really want to help them manage pain, increase the mobility as much as we can, and get them back to normal function with desensitization exercises and muscle performance exercises as much as possible. All right, party people, it is time for my apologies if you didn't pause to read. Question number 2. A PTA, and the answer is A, wasting of the height. Last up for questions. A PTA, and the answer is B, extension of the